you doing, class? My name is Wilson. The special case that I'm going to be showing you today comes from NYPQ. The patient that I had was a 52-year-old female patient who was coming in for an x-ray of her left knee because the following day she was going in for surgery. The patient mobility she was slight mobile. She walked with a cane, and as well as she couldn't bear to keep a certain position for a while, so she had to move a lot to relieve the pain that she was feeling. She also told me that her knee was red, swollen, and tender for a few weeks now. And when I took her history, she told me she had a history of diabetes. She had a history of arthritis. There was no sort of trauma no sort of trauma that happened to the knee, so it's definitely some type of pathology. And the patient was also hypersthenic. Now, when I received all this information, the history, and what I observed, the goal in regards to patient care was to not add on to the pain that she was feeling. So this meant that when I was going to position her, I put in my mind that I was going to have to work efficiently, as well as the patient was hypersthenic, and I also observed that she would run out of breath really fast. So in regards to positioning, I didn't have to move as fast just to help her keep up. And now I'm just gonna show you the projections. The projections that I did were AP, lateral, weight bearing, and sunrise. Now, when positioning her for the AP, as we all know, the CR is coming in 1 inch below the distal to the apex of the patella, as you can see here. When positioning her for this position, it was a bit hard because she couldn't keep that leg straight because of the amount of pain that she was having. She was shaking her leg a lot. So for this projection, we had to move really fast, and we were able to get this picture. The tech took it, and when moving to the lateral, this one became a bit more difficult because she couldn't bend her knee as much because of the pain. So when positioning for this, we had to also work really fast, and thankfully we were able to get the whole knee. The technician looked at it and he said he took it. And then moving on to the sunrise. So okay, and then for the sunrise as well, for this one was the hardest of them all because for the sunrise I was gonna do it on the table. Now the patient was hypersthenic, and I tried moving her on the table with just by myself, but that failed. So I had to ask the help of another technologist to come in and help me, and we were able to get her on the table. I positioned her in a supine position, and then when I asked her to bend her knees for this sunrise view, she told me that she could not do it anymore because the pain was so severe that it was too much for her. So what I did was I just gave her some time, so it can help the pain. And when I came back and asked her if she can do it now, she still told me that she couldn't do it. So then one of the technologists told me that in order to help with this, to ask her to bend both knees, and I did so, and then it did help. However, she can only hold this position for a really short amount of time. So when I put her in this position, I had to run back and take the exposure, and thankfully we were able to get the radiographs. Now, as we all know, when it comes to a radiograph of the knee, we're supposed to see a symmetrical joint space right here. And as we can see here, there is no joint space right here, as well as there are some bony spurs at the edges, at the lateral side right here. And when we come over here to the sunrise view, we can also see even more bony spurs right here, right here, right here. And the pathology that she had is more evident in the lateral view, which is right here, because there is no joint space. Right here, right here. And there's some slight rotation as well, as you can see here. But the technologist took the image because the patient was in pain, and we weren't going to be able to fix this again. So as you guys can see here, there's some type of pathology that exists here. And when I got the lab report, the doctor said that yes, she was going in for a complete knee replacement because she had severe osteoarthritis. Now, as we all know, osteoarthritis is like the degeneration of the cartilage, but between the joints. And in regards to here, she had it so severe that her medial meniscal disc was missing. As you can see here, there's some pathology right here, right there. And then as I showed you before with the sunrise view, she had plenty of bony spurs here. So yeah, so she was going in for I did some research and she was going in for a arthroplasty surgery, which is basically a complete knee replacement surgery by replacing the distal portion of the femur, as well as a bit of the proximal portion of the tibia, and replacing it with a metal, which should help with the mobility and the flexion of the knee. And after taking this patient and doing these positions, I learned a lot more about osteoarthritis in regards to the patient and how we radiograph. And one of the things I learned is that not all radiographs are gonna come out perfect, because every patient is different. Meaning that not all our radiograph is gonna come different. The important thing is that we're able to get a diagnostic image, but at the same time keeping the patient care at an optimal level. Because as we all know, the patient is the number one aspect during the procedure. As well as I also felt like I could have worked more efficiently when I brought the patient into the room. The room was not set up, and that's what something I would like to work on, to work more efficiently, to have everything prepared so that when the patient comes in, it won't take the procedure won't take as long. And as well as certain technique factors with osteoarthritis and with osteoarthritis and other diseases, I want to know when or not to increase or decrease the technique, so that we're able to see any type of pathology on the radiograph. And I hope you guys enjoyed my presentation. Thank you.